everyone, and welcome to the ACP Problem Solving in Oncology webinar series. And I'm Helen Hockings. I'm a medical oncology registrar from Barts in London, and I'm going to be chairing our session today. Starting our first talk is Michelle Lockley. I'm really pleased to introduce her. She's recently been made a Professor of Medical Oncology at Barts Cancer Institute, and she also works as a consultant medical oncologist at UCLA in London. Her lab at Barts Cancer Institute focuses on both viral therapies and adaptive therapy in high-grade serous ovarian cancer, and her clinical research, or one of her clinical research interests, is in female germ cell tumours, and she is a member of MAGIC. So without any further ado, I'd like to welcome Michelle.
Okay, so yeah, I'm going to talk to you today about ovarian germ cell tumours. Okay, so as you are probably aware, as with all tumour types, there are a large number of different histologies that happen in the female ovary or in the ovary. In the malignant histologies that happen in the ovary are epithelial. That's the overwhelming majority of what you'll see clinically. And okay, so something in the chat. Okay, and if any of you have done ovarian cancer jobs before, you will know that your clinics are absolutely full of patients with this histology, sorry, my slides are not advancing very well. There we go, high-grade serous ovarian cancer makes up the majority of what we do, and Dr. Miller's going to talk about that later. But you can see there's a huge number of other histologies, and a very small proportion of them are germ cell tumours. So it does sort of maybe future webinars, you can think about some of these other histologies that you won't hear about today. Okay, so I'm really sorry, I'm struggling to advance my slides. Okay, and so germ cell tumours in the ovary account for a tiny proportion of cases, less than 5%. And this is data that's been collated from across the world and across time. So extremely rare tumours. So today, I thought I'd talk to you a bit about the histology, the classification of these tumours and some of the clinical features and guidelines for management. We're going to cover a little bit of biology. As I said, we'll cover guidelines. I'll put in lots and lots of references. But what I'm figuring is because these are so rare, very few of you in the audience are going to actually manage these as your day job when you qualify. It's not going to come up much in your exam, certainly won't be pass or fail. So I figure that gives me a bit of freedom to talk about some of the more contentious issues, some of the things that we really don't know, and I'm going to end with a bit of a rallying cry, a call to arms. Okay, so even within this rare subtype of ovarian germ cell tumours, they are further subdivided by histology. And here on this side of the table are the primitive ones. So everyone would agree that these histologies are all definitely, frankly, malignant. The ones on the other side of the table, though, this is a mixture of diseases that cover the definitely benign things like mature teratomas and dermoids, and then immature teratoma, which is a bit contentious whether it's considered a malignant tumour or not, and different people would actually say different things about that. And so I'm going to talk to you today about the diseases highlighted in bold. I won't talk about choriocarcinoma. It's extremely rare, managed in 1 or 2 centres in the UK. I definitely won't talk to you about the benign diseases. These ones, so sometimes teratomas can undergo somatic transformation events. This is like, very, very rare and very, very nasty in that if they're early stage, you can resect them. But if they metastasize or spread, they tend to be very resistant to systemic therapies. In general, they start to exhibit the different histologies, and we tend to treat them as if they were that histology found at a more usual site. So a teratoma that transforms into a squamous cell tumour, we might, for example, choose to use cisplatin to treat that. And sometimes they can transform into these very aggressive sort of neuroectodermal tumours. We used to call them PNET. Increasingly, they're called Ewings. Anyway, they're rare and strange combination chemotherapies and no real consensus on how to treat them. So I'll talk to you today about these ones highlighted in bold in the table. So the first thing to say about them is that the survival from these tumours is absolutely fantastic. You know, this is better than we see in solid oncology in any other tumour type. And you can see that most relapses or deaths in this particular graph happen in the first couple of years. So if patients make it out to a couple of years post-diagnosis, they tend to survive long term. So really fantastic overall survival. If you contrast that the cancer that Rowan's going to talk to you about later today, high-grade serous epithelial cancers, nearly everyone is dead within 10 years. Very few people survive 5 years. So it's a completely different type of cancer to treat. And I think this is one of the reasons why I quite like treating them, because they have different outcomes. Another really important thing to note about germ cell tumours is that age distribution is completely different. So for most ovarian cancers, incidence is very low before menopause, and then at sort of the time of menopause and beyond, the incidence increased steadily. And like solid tumours, they're a disease of old age. In contrast, germ cell tumours here in green, you can see this little blip, but when you look at the inset, they are a disease of adolescents and young adult, a true AYA tumour. And so to the extent that if you're in this age group and you have a malignant tumour of the ovary, chances are it will be a germ cell tumour. And this is really important in thinking about how we treat these cancers, the fact that they're curable and they happen to young people. So when we're treating young people, which we don't do all that often as medical oncologists, the concerns that those patients have are completely different. So these young women care an awful lot about what they look like in general. So they don't like gaining weight and getting, out of shape during their chemotherapy. They don't like losing their hair. They don't really like midline laparotomy scars that make them self-conscious about, wearing a belly top or a bikini. Because they're going to be cured, things like fertility and early menopause and those kind of long-term concerns are really important to them. And of course, we don't have to think about those in our older women. And when we go into, when we're expecting to cure people, if they're stuck with a toxicity that we may think of as relatively trivial in older age groups, something like peripheral neuropathy, for example, if you have to live with that for 60 years when you've been cured of your cancer in your early 20s, that has quite an impact on your life. And so, adult oncology, many patients with these ovarian germ cells will be treated by people who are much more used to treating adults with epithelial cancers, where we're very kind of relaxed about aggressive, debilitating surgery. We don't mind about intensive surveillance. We're thinking in a palliative mindset. And of course, we have to switch that completely when we start to look after younger patients. I sort of said this already, they're germ cell tumours are a disease of teenagers and young adults. They are a group of different histological subtypes. And I want to kind of argue today that although this is so rare, it's kind of difficult to think about it in the detail. But actually, all of these histologies that we see arising in the germ cell tumours are different diseases, and we should treat them as such. So the next point is a bit contentious, okay, and this is where I was sort of going off piece and thinking it's just good to talk about something that's interesting and maybe something for you guys to think about in the future, is that if we have these young patients, we don't really like giving them very nasty toxicities, we nearly cure them all, maybe, just maybe, we're over-treating some of them, and can we understand who they are and what can we do about it? Okay, so I promise a bit of biology. So just like a lot of cancers that happen in children, mutation rates are actually rather low and rare in these diseases, and that kind of contrasts to many tumour types that we see in older age groups. Having said that, there are some mutations that are recurrent, so mutations in KIT and RAS occur in dysgerminoma patients. Extensive aneuploidy, so copy number variation, is a much more important feature of germ cell tumours. And we sometimes see these copy number gains in certain key genomic regions. So, for example, PIK3 kinase and AKT in yolk sac tumours. And again, you may have heard, if you've if you've done any testicular cancer work, you'll know that a particular aneuploidy of chromosome 12, so a gain of chromosome of 12p, is very common in germ cell tumours arising in the testis and also in the ovary. But there are some exceptions, and one of those is immature teratoma. So these kind of different genomic features feed into this idea that the different histologies probably are different diseases and probably do require different management. The other thing that's coming is this overexpression of microRNAs, and particularly MER371, 373, and MER302. And these have been shown in the testis to be really important in predicting chance of relapse and future prognosis, and also potentially being used as to detect as an early detection marker. So, having sort of said at the beginning that this is an AYA disease, the other thing that's important is that these genomic features, sure, they happen in our typical age group, but they also happen when these tumours arise later in life. So for me, it's rational to think that here we have an AYA disease. The biology is the same across the age groups. If we have occasional rare cases when they occur in older women, we should probably think about managing them in the same way as we do younger women. And equally, all of these features are also seen in testicular tumours. And so again, it's possible perhaps to extrapolate knowledge from testicular cancers into the management of these tumours when they arise at a different anatomical site. And of course, because tumours in the testis are nearly all germ cell tumours, it's a much more common disease when it occurs in the testis. So they're more likely to have bigger clinical trials, and we're more likely to learn from them. But I think it's of interest to try and apply that knowledge when the tumours occur in other anatomical sites and different genders. One thing that is different, of course, is the clinical presentation. So unlike epithelial cancers, which we'll hear about later this evening, germ cell tumours tend to present with early stage disease. So in ovarian cancer, we use FIGO classification, where stage 1 disease is confined to the ovaries, and nearly all of germ cell tumours present with stage 1 disease. And of course, a cancer arising in the pelvis can grow a lot bigger than a cancer arising in the scrotum. And so these women tend to present with very large ovarian masses, often without metastasis. And so their presenting features are very commonly a palpable mass, abdominal swelling. This could be painful. Sometimes they get an acute abdomen, and often that's because there's a torsion of the ovary which causes an acute event. But this, you'll see, is very different to the presentation of epithelial cancers, where they tend to present with stage 3, stage 4 metastatic disease, and the presenting features all relate to that metastatic phenotype. Okay, so it's occurring in young women, they're very curable, the disease is localized, fertility-sparing surgery is the standard of care, full stop, everyone agrees, and that's even the case in advanced disease. And the reason it's the case in advanced disease is because they're also extremely chemotherapy sensitive. So nearly everyone just needs one ovary taken out. In adult guidelines provided by ESMO, they recommend that some patients with very early stage, low grade disease can then be managed after their surgery with just surveillance and no need for further adjuvant treatment. And in the adult guidelines, they define these subtypes as being ones that do not need chemotherapy after their initial surgery. There's another set of guidelines for AYA patients, also through ESMO, but defined by SIOP, which is an organisation, Society for Paediatric Oncology. And so they allow post-op surveillance in FIGO stage 1A disease, so that's just confined to one ovary, with any histological subtype. So some slight differences there. And when both of the guidelines provide some guidance on how to manage post-op surveillance, and here this is the sort of the table that came out of that I've just taken out of the paper. And so you can see it's testicular cancer, and people do this as well, where they followed up monthly for year 1, 2 monthly for year 2, 3 monthly for year 3, which is kind of classic for testicular cancer. And they have tumour markers, and they have, in my opinion, rather a lot of imaging. So lots of X-rays, lots of CT scans equals a lot of radiation in young people who are cured, in my opinion. In the SIOP guideline for AYAs, it's really very similar, but the big difference is here they're suggesting MRI scans rather than CT scans for follow-up. And I tend to do this for all patients regardless of age. I'll MRI them in preference. However, look, when you're thinking about your exams and questions that are going to come up and what are the international guidelines, this is the document that you need to read. These are the ESMO guidelines telling you how to manage germ cell tumours. And although here I've put things that definitely you can have post-operative surveillance, both sets of guidelines provide some details on what they consider to be borderline. So you have an option of surveillance or chemotherapy. but really across the board, both sets of guidelines beyond that suggest BEP chemotherapy, full stop for everyone. Okay, so BEP, a combination of bleomycin, etoposide, and cisplatin, and this, it is quite a toxic regime. I don't know how many people on the call have actually given it or been involved in patients who have had it. In young patients, get on with it reasonably well, but as you get older, it becomes more difficult. And certainly some of these lung side effects from bleomycin happen twice as often in older patients. So there are lots of toxicities associated with this regimen. And referring to what I was saying earlier, if you're 25 and you have tinnitus for the rest of your life and you're cured of your cancer, you're happy that you're cured, but you wish you didn't have tinnitus. So I think there is some room to trying to think around this a bit. Okay, so I think what I'm going to do now, the next few slides, I'm going to talk you through the guidance for adults, which of course is what you're interested in most, and then I'm going to talk about a few controversies and things that other professional groups do. Okay, so yolk sac and mixed germ cell tumours we'll consider as the same thing. The mixed germ cell tumours usually means that they've got an element of yolk sac tumour within them. And as we've just said in our adult guidelines, if you stage 1A and B patients who have had proper surgical staging, you can just watch them according to that surveillance regimen we just described. And everyone else gets BEP chemotherapy. Okay, so this. Give me a pause. Sorry, I've got a visitor. Okay, so in paediatric guidelines, for a very long time now, over 20 years, paediatricians have felt very strongly about trying to avoid cisplatin, because making children deaf with cisplatin and giving them tinnitus actually has an enormous impact on their future lifestyle chances. So they've really tried hard to avoid cisplatin. And Jeb uses carboplatin rather than cisplatin, the etoposide and bleomycin. There's a slightly different dose. But the emphasis here is to try and avoid ototoxicity. And they have been doing that safely for over 20 years now. The AYA guidelines, I think, are probably the most rational, to be honest, because they give you a lot of options. Can have BEP, you can have Jeb like the paediatricians, or if you're a bit concerned about the bleo, you can dose reduce the bleo or substitute it for ifosfamide. So there's more options here. Okay, I'm not going to talk about yolk sac anymore today, because pretty much everyone would agree that this is a cancer that really does need chemotherapy. Okay, so we're going to talk about dysgerminoma next. Dysgerminoma is the sort of opposite end of the spectrum. It's essentially the female equivalent of seminoma. Really the most platinum sensitive germ cell histology. Our ESMO guidelines for adults say that stage 1A can have active surveillance, and 1B and 1C. So generally stage 1, you can do the active surveillance program. And I should probably say at this point, actually, this active surveillance has never been prospectively evaluated. So I think there's a sort of gap there for the future. But then all other stages, they give BEP again. They do have this caveat that patients who are over 40 years, and actually dysgerminomas, we do see more in older age groups. So older patients, they allow you to drop the bleo altogether. So even adults are kind of amenable to chemo de-escalation in certain circumstances. And the reason for the dropping of bleo we discussed already is because of this double risk of lung toxicity in older age groups. Okay, in AYA patients, we looked to see whether carboplatin-based regimens were as safe in dysgerminoma as cisplatin-based regimens. And so this is pooled data, this is published not long ago, pooled data from 6 clinical trials. Some were purely for children and some were sort of an AYA population, so some who we would think of as legally adults, even if not, with the caveat that this is an AYA disease. And what you can basically see, as before, the survival is amazing. It's really, really good. Doesn't matter what you give them, it works. No detriment to giving carboplatin. So we sort of think that in AYA patients, people in general, like paediatricians, are happy with the idea of giving carboplatin to avoid the neurotoxicity. So this is the argument that dysgerminomas and seminomas are basically the same disease. And there's lots of reasons for thinking this. So they do have distinct genetic features from other germ cell histologies. So they express these pluripotency markers, things like NANOG and OP3/4 and SAL4. They very commonly have mutations and amplifications in KIT and RAS that we don't see in other germ cell histologies. And this aneuploidy at chromosome 12, the isochromosome 12 or 12p, is a hallmark feature of both diseases, dysgerminoma and seminoma. When you look at them under the microscope, they look the same. Now, I'm not the best pathologist, so everything looks a bit the same to me under the microscope. But we're looking at these sheets of tumour tissue in dysgerminoma and seminoma that really look identical. And I'm told that even pathologists, if you showed them just the tumour on its own, there's no way they would be able to tell you morphologically which one's in the ovary and which one's in the testis, unless there's a bit of normal testicular tissue nearby, in this case, a rete testis. The immunohistochemistry is the same in the two tumour types. And very recently, in the 2022 urological WHO classification, seminomas was put into the germinoma family of tumours. So there's increasing evidence that dysgerminoma and seminoma are biologically the same disease. Another thing to say is clinically, these are the ones that do best out of all of the germ cell tumours. So if you look at this 5-year survival for all ovarian germ cell tumours, it's around about 3/4 of patients for all tumours are alive at that time. Whereas dysgerminomas and seminomas, it's more, it's getting close into the 90% 5-year survival. So they're exquisitely sensitive to platinum. And of course, in seminomas, there's been evidence for a number of years about using just single agent carboplatin, so not even combination chemotherapy. And the first evidence for this was from over 10 years ago, comparing adjuvant high dose single agent carboplatin to radiotherapy and adjuvant treatment of localized seminoma. And you can see that the survival curves are basically the same. And more recently, this study that was conducted at Barts, but it actually reflects a supra-regional practice in which a single agent study in which patients with metastatic seminoma received AUC 10 carboplatin, and again did it extremely well. And so single agent carboplatin has been adopted in our region for the treatment of dysgerminoma and seminoma. But the clinical trials, carboplatin really in adult dysgerminoma with essentially untested. This is, in fact, a typo. There's only one trial in the 1990s of carboplatin in adult dysgerminoma, which didn't use sufficient dose intensity, in many people's opinion, and was terminated early. And this is an ongoing problem, probably because of how rare dysgerminomas are. That if we did a recent search on clinicaltrials.gov, and there were 59 trials for seminoma and only 7 for dysgerminoma and only 1 recruiting. And I think this just reflects the fact that the tumour type is rare. So we're kind of strongly arguing and saying that in trials of systemic chemotherapy for seminoma should now include some dysgerminoma patients, because dysgerminoma patients have been getting BEP for like 3 decades now. There's been no clinical developments, no change. And it's extremely difficult for us to do a trial of such a rare disease. But perhaps by lumping them together, and perhaps by having clinical trials that include patients of all ages, we may learn, and some women may benefit from some treatment advances. Okay, so immature teratoma is where things really get a little bit sticky. So in our ESMO guidelines, which I stress is what you need to learn for your exams, again, very early stage diseases, so stage 1, this means confined to 1 ovary, can have active surveillance. So stage 1A confined to 1 ovary, and stage 1B in 2 can have active surveillance if they've been properly surgically staged, but everyone else gets BEP, again, 3 to 4 cycles, so our favourite chemotherapy regimen. But paediatricians don't really use chemotherapy at all, and many paediatricians would tell you that it's not a malignant histology. They talk about malignant germ cell tumours and immature teratomas as something different, the exception to that being grade 3 immature teratoma. So the grades of immature teratoma refer to the amount of primitive neuroectodermal tumour that is seen in a high-powered field. It's an extremely ancient staging system that goes back to the 1970s and was based on a study in which there were about 50 patients, 50 cases. It's quite a difficult thing to do, and it requires 2 expert pathologists to do the grading. There's a kind of ongoing debate about what grade actually means in an ovary confined tumour in particular. And some kind of moves to move it to a 2-stage, either grade 1 or grade 2, just a 2-stage rather than a 3-stage grading system. So in certain cases of metastatic grade 3 immature teratoma, some paediatricians would consider chemotherapy, but many consider it not chemotherapy sensitive and not even malignant. But in the adult world, we think of it as malignant, and we advise giving 3 cycles of BEP. Okay, so there was this piece of this paper that came out a few years ago asking how is surveillance safe in immature teratoma? And so they extracted data from 7 pediatric and 2 adult trials. And this is magic. Helen referred to this earlier, the Malignant Germ Cell International Collaborative, of which I'm currently vice chair. So we pulled these trials and we looked at outcome. And you can see that as everything so far today, the 5-year event-free and overall survival were fantastic in pediatric cohort and also in the adult cohort. The children, hardly any of them had chemotherapy. They were nearly all treated with surgery alone, but all of the adult patients received chemotherapy. And so this is probably because this is, what our guidelines tell us. So what they were able to conclude was that post-operative chemotherapy did not decrease relapse in the pediatric cohort. So yes, surveillance is safe in children, but the role in adults remains unresolved. And if you go back to those bell-shaped curves of the age distribution, and you see where the peak of it is, I find it hard to reconcile the idea that you should treat a 21-year-old any different to how you treat a 17-year-old. So I was kind of interested in this idea, and we did this retrospective series that Helen was involved in of all ovarian germ cell tumours treated across 4 UK hospitals. And we looked back 12 years. We found only 138 patients, which tell you how rare it is, but we had a load of patients who were over the age of 18. We found that BEP was toxic. I'm not going to go on about this again. One patient died of chemotherapy-related leukemia, which of course is a tragedy. And when we looked at distribution by age, above and below 18, we found that it really didn't matter that much. So this is just the patient characteristics in our cohort study. And I'm just highlighting where there were differences. So the incidence of immature teratoma was a bit higher in the younger age group, and the incidence of mixed germ cell tumour was a bit higher in the older age group. And then we looked in this terribly aged over 40-year-olds, and we did see these differences in that over 40-year-olds tended to have slightly higher stage disease, and they also tended to have even more of the mixed germ cell histologies. And you'll see that the N here, the number of patients in total, is tiny. So these data, it's really difficult to work out if we see differences. Is it because the patients are old? Is it because they had high stage disease? Is it because they've got this particular histology? And are they all interrelated or separate? We can't answer that from these data. But when we look at survival, overall, all histologies, our whole cohort put together, you can see that the survival is basic. Sorry, this is event-free survival, so survival without relapse rather than overall survival. You can see it's the same regardless of age. However, our over 40s do an awful lot worse. And what we don't know is that because the disease is worse or because we couldn't treat them as aggressively? My inkling is that the disease is different because when we looked at these individual patients, they had rather aggressive chemotherapy, but of course the numbers are very small and we can't resolve that here. Survival did differ according to the histological subtype. So as we said at the beginning, dysgerminoma is doing exceptionally well, and these somatically transformed things doing really rather badly, and everything else falling in the middle. Okay, so this is the question about immature teratoma, and this is small numbers, speculative. I think it's of interest. And I think it warrants further investigation, but I just wanted to share it with you today. So when we looked at patients who had any chemotherapy, patients who had any chemotherapy and patients who did not have any chemotherapy according to the underlying histology, and then we looked at how many of them had a progression or relapse event. In these 3 histologies, dysgerminoma, yolk sac and mixed, which we say are definitely malignant, and that's not argued. In all of those histologies, the patients who had chemotherapy did better than the patients who did not. And of course, this is all confounded because we're more likely to give chemotherapy to higher stage disease, but you get the feeling that chemotherapy is probably benefiting them. Whereas in immature teratoma, we did not observe that relationship. We then looked at patients with immature teratoma who had measurable disease. So either patients who were being treated neoadjuvantly or patient who had a relapse and had not had chemotherapy previously. And then, so they had a lump that you could measure and then they had chemo. With only 3 patients, but none of those patients had any degree of radiological response at all. And that does compare to our other histologies. So dysgerminoma, all 10 patients in which we could measure a radiological response did respond, and yolk sac, it was 4 out of 5. So it suggests, at least that immature teratoma is perhaps less chemotherapy sensitive than the other subtypes. So I've just sort of said that. So in immature teratoma, we didn't see radiological responses. We didn't reduce the chance of future relapse by giving neoadjuvant or adjuvant chemotherapy, and nobody died. And we kind of believe this, and we believe the paediatricians. They've got more experience of managing this disease than we have. And so our current regional practice at UCH and Barts for all patients with immature teratoma is they have their initial surgery, then we watch them. And we accept that they sometimes recur. And we take a very pragmatic approach to additional surgery. So we operate if it's giving them problems or if it's likely to give them problems in the future. And we'll only give chemotherapy if there's really no other options. And honestly, I've not done it in the 7 years I've been a consultant at UCH. Okay, so can we explain this lack of chemotherapy response in immature teratoma? Well, biologically it looks different. It's got more stable copy number than other germ cell tumours. It doesn't have 12p gain. The copy number profiles don't differ according to IT grade. And so it just begs the question, are we right in what we're doing, managing these patients with surgery alone? And also, is there a need to rethink the pathological classification? And we had an opinion of that, and it's published if you want to read it. There are about 1 million other questions about immature teratoma, which is bizarre considering how rare it is. So things like the role of grade, some people have classified yolk sac microfoci in the past as being okay in IT, and now they're not. They produce AFP. Then we have these sort of benign manifestations, gliomatosis and growing teratoma syndrome, somatic transformation I alluded to earlier. So for a tiny disease, it's got loads and loads of questions, to the extent that we held a consensus conference. And if you're interested in the small print stuff, we published that as well. So do have a read. Okay, so just coming to the end now. So I think what's really interesting actually is not, one question is, can we make treatment less toxic for the patient who we know we're going to cure? But to understand that, we need to know who are the patients who are not going to cure, who are the bad prognosis ones who don't survive. We've already said that age matters, histology matters, stage does matter as well. And then we have biomarkers that can help us, so decline in tumour markers. If the tumours are producing AFP decline is very indicative of response. And microRNAs are emerging, and perhaps other molecular features can help us. People have tried to classify all ovarian germ cell tumours using a similar model to the one that's used for testis, the IGCCCT, into good, intermediate, and poor risk. And in their series, they were able to separate the good intermediate from the poor. But actually, I think you guys could probably have done that after this lecture. So the dysgerminoma patients are always good. If you have lots of metastases, then you'll do badly. If you use very high tumour markers, you'll do badly. So I'm not sure how much that helps us. This group have another update of this paper and a validation set, which they're trying to publish at the moment. So there'll be an update on this quite soon. But I think the big questions going forward are, can we improve the outcomes from these poor prognostic groups? We haven't talked at all about how to treat relapsed and resistant disease, and that's because there is no consensus. They tend to be treated in specialist centres where people have their preferred combinations. And can we identify novel therapeutic targets? And as I alluded to earlier, I think we really do need data from more patients. And in adult germ cell tumours, we're only going to do that by ganging up with other groups of professionals who treat these tumours more, by which I mean the paediatric oncologist, the TYA oncologist, and the uro-oncologist. And we have one trial that's open now around the world that is seeking to do exactly that. So this trial, AGCT1531, is a randomized phase 3 trial with lots of different treatment strata for low and standard risk extracranial germ cell tumours. So this is enrolling children, teenagers and young adults, male and female patients. So trying to transcend those kind of traditional professional boundaries and the silos in which we work. And with a big translational component, so maybe we'll learn something. I think that's it from me today. These are the people who I've sort of worked with on these things and who've contributed to some of the papers. So I guess question, I know I've gone a bit over. I'm sorry about that. Okay, question time.
Thanks, Michelle. That's a really great talk and a really interesting topic that's not covered very much. So I know obviously, it's a really interesting point you make about applying knowledge from the testicular cancer group and their clinical trials. Other than the carboplatin AUC7 for dysgerminomas, are there any other clinical trials you think could be extrapolated across into the female patient group?
Okay, so yeah, so the AGCT 1531 is quite a good example of that. It becomes quite complicated because that's separating patients. It's sort of defined low risk and medium risk, and they're sort of lumping tumor types together. So yolk sac tumors occurring either in men or women, whether they're early stage, and different it's sort of testing out a number of different chemotherapy regimens, and also investigating surveillance for patients with a low risk disease. So yeah, so I think questions about whether it's okay to observe teratomas, I think you know, I sort of raced through yolk sac tumors today, but potentially whether there are chemotherapy modifications that can be used in yolk sac tumors and occurring in different in patients of different sex or gender. Yeah. What's interesting about germ cell tumors is it's still all really chemotherapy based. So there haven't been a huge number. It's mutationally poor. It does not express sort of neoantigens or other sort of features that you might think immunotherapy could work for. So it still is really chemotherapy. It's still about modulating and modifying chemotherapy regimens that we don't often think about these days in solid tumor oncologies.
The AGCT 15, is that going to include an arm with the immature teratomas having surgery alone versus chemo?
Yeah, it is.
Great. We've got a few questions in the chat box. So the first one from Richard is, do you know if other centres do not give chemotherapy to immature teratoma patients, and do patients ever push for chemo?
So the first one, no, patients, I've never had a patient pushing for chemotherapy, but I think it's probably once you start talking about the side effects of BEP. Other centres, so paediatric centres around the world, yes, and places that specialise in AYA patients. So of course, TYA and AYA is slightly weird definition. So TYA is more of a UK classification that goes to sort of about 24, and AYA is beyond that. So yeah, centres that treat AYA patients tend to be more comfortable, and paediatricians certainly do. So in our centre, it's a regional referral network. So we take referrals from the Anglia region, including Cambridge. So we've got a referral population of 7.5 million. So that's what we're doing, and we're following them up prospectively.
So would that go up to 25 then for patients being in that group and not treated?
Yeah, so patients who are managed by TYA teams are more likely to use surveillance.
And then a question from Rachel, are outcomes worse in patients who are not given bleomycin because of likely pulmonary toxicities? Yeah,
I don't know if I can answer that, because I think it just becomes, it's never been done in a randomized way. And of course, we're here giving, all of the things that matter, like the underlying histology, the age of the patient, the reason why they haven't had bleo. So I don't think anyone could answer that question. It's a bit like when we dose reduce Taxol in epithelial ovarian cancer, people always say, is that going to make a difference to my outcome? And nobody knows because we've not tested
it. Any more questions at all? Wait one more minute and then we'll move on to the next talk.
It's wonderful, because when normally people go mental when I start saying these things. You're right, it's contentious. I should stress it. It's not guidelines. The guidelines say one thing. These are just interesting points that I think are worth exploring.
Everyone obviously agrees with you today, Michelle. No comments. Dr. Rowan Miller is a consultant medical oncologist at Barts Hospital in London, and she's the deputy lead for the Centre of Experimental Cancer Medicine at Barts also, and she specialises in early phase clinical trials there. And she recently led the ESMO consensus recommendation paper on HRD testing and ovarian cancer. And her talk today is going to be on the management of high-grade serous ovarian cancer with a focus on HRD testing as a biomarker. So when you're ready, Rowan, please go ahead and share your slides. Thank you.
Yeah, so moving from one extreme to the other, from a very rare type of ovary cancer to the most common type, I'm going to be talking about the management of high-grade serous ovarian cancer, particularly with a focus on the first-line treatment options, because really in the last few years, there's been an explosion of really significant, highly positive clinical trial data, which has changed what we do on a day-to-day basis, but it's also significantly improved outcomes for our patients, including significant gains in overall survival. And in order to understand that, we need to know the background and the relevance of both HRD or homologous recombination deficiency testing and BRCA as predictive biomarkers. And at the end, I'll touch on briefly on the management of recurrent disease, but that's really a whole lecture in itself. So I think you may have seen something like this from Michelle before, but it just shows the different subtypes of ovarian cancer. And when we traditionally talk about ovarian cancer, we're meaning epithelial ovarian cancer, which accounts for the majority of cancers, of which about 90% of which high-grade serous is by far the most common. And you can see here by this pie chart that serous cancers represent about 70% of all cancers, with endometrioid, clear cell, and mucinous, and then very rare transitional cancers representing much smaller amounts. Now, there's marked racial variance, so particularly, for example, clear cell is much more common in the Far East, so in Korea, Japanese, Chinese population, it represents almost a quarter of all cancers, and that's probably because of a higher incidence of endometriosis, which is the putative precursor lesion. The other thing is worth noting is that there's a marked sort of discrepancy between stage with regards to incidence. So the majority of serous, particularly high-grade serous cancers, present with advanced stage, so FIGO stage 3 or 4 disease, that's disease outside the pelvis, where some of the rarer histologies are much more prevalent in the early stage. So clear cell, for example, represents almost a quarter of early stage cancers, whereby its overall incidence is relatively small. So high-grade serous, advanced high-grade serous is the bread and butter of what we see and represents about 90% of the patients that we treat on a day-to-day basis. Now, this chart shows the natural history of advanced ovarian cancer, really prior to the widespread introduction of maintenance therapy. And here what we're doing is we're charting tumour volume using CA125 as a surrogate against disease-free survival. And what we see is in the initial, patients often present with very high CA125s. They respond extremely well to platinum-based chemotherapy and surgery. And often the majority of patients at the end of chemo and surgery will be disease-free or have no evidence of disease on imaging. And that prior to using maintenance therapies, the platinum-free interval, PFI, was between about 12 and 18 months. And then we see this typical pattern. You get a rise in CA125, we give more chemotherapy, you get a fall. And with time, the interval between subsequent chemotherapies gets shorter and shorter, and the benefit of chemotherapy gets less. And patients ultimately go from platinum-sensitive disease, that's disease that recurred within 6 months of the last platinum chemotherapy, to developing platinum-resistant platinum-resistant disease. And once you have that, the response rate to subsequent therapies is very low. The median survival is about 12 months, and the median progression-free survival of any chemotherapy is only about 3 or 4 months. So what we really want to do is focus on this early stage disease where there is really the only opportunity for cure. So even prior to all these novel therapies, which I'll talk about, there were a small number of patients with stage 3 or stage 4 disease who were only treated with surgery and standard carboplatin-based chemotherapy and remain free from recurrence 5 or 10 years later. And what we hope is by introducing the new therapies in this window will increase the number of patients that fit that criteria. So here, this timeline just is to show you the sort of explosion of positive clinical trials we've had recently. So this is in the first line maintenance setting. That means for patients who've had chemotherapy and or surgery and have had a response, and therefore you give them treatment to try and maintain that response. It's worth noting this timeline is not drawn to scale. So we had over a decade ago, the 2 positive studies using the VEGF antibody bevacizumab, and then it wasn't until 2018 that there was any other positive data in this field, and that's with the advent of PARP inhibitors. So before 2019, so about 3 years ago, the management of advanced ovarian cancer. And here we're talking predominantly about high-grade serous, but the management's the same for the other subtypes, at least previously. Patients would either undergo primary cytoreductive surgery, that's with an attempt to remove all visible disease, followed by 6 cycles of carboplatin and paclitaxel, and then they'd go on to follow-up, 3-monthly follow-up, usually with CA125s. Or if they had disease that wasn't amenable to surgery, or they were perhaps fairly unwell because of their burden of disease, recurrent ascites, etc., we treat them with neoadjuvant chemotherapy, again with carboplatin and paclitaxel, with a view to reducing the disease burden and facilitating surgery in between the chemotherapy. And then again, they would be treated with 3 cycles of post-op chemotherapy and go on to follow up. We did have the option for bevacizumab, but certainly within the UK population, although initially approved for all comers, more latterly has only been available for those with high risk features. So those that had inoperable disease, those that had residual disease following their surgery, be it primary or interval surgery, and anyone with stage 4 disease. And that's on the background of the 2 pivotal bevacizumab trials. Now, as I said, these are over a decade old, but until recently, there wasn't anything better. So the GOG study was an American study that took patients with stage 3 or 4 disease, and they were randomized to one of 3 arms, either chemotherapy alone, standard 6 cycles of treatment, carboplatin and paclitaxel, or they had chemotherapy with concurrent bevacizumab and then placebo maintenance, or they had chemotherapy with bevacizumab with the chemo and then as maintenance. And in this trial, they were given it for 15 months. In the ICON-7 trial, which was a UK study, patients either received chemotherapy or chemotherapy with Bev concurrently and then as maintenance treatment. And both of these studies, it's a somewhat arbitrary cutoff of duration of treatment, but it's felt that 12 to 15 months covers the greatest, the high, that's when most patients will recur. The GOG study showed a small improvement in progression-free survival. So, at that point, a 3-month improvement in PFS was considered a highly positive trial, hazard ratio of 0.77. And that was only when bevacizumab was given both with chemotherapy and then as maintenance. But disappointingly, this didn't translate into a survival benefit. So there was absolutely no difference between the 3 arms in overall survival. And then when we look at the ICON-7 trial, again, a minimal improvement in progression-free survival of less than 2 months. But interestingly, when they broke it down by high and low risk groups, the high risk groups being, as I said, residual disease, stage 4, inoperable, there was a greater magnitude of benefit, so about 5-month improvement in PFS. And then when we look at survival, the top 2 lines are those for the non-high risk patients, really no difference in overall survival, about 49 months for both, but in the high risk patients, an improvement of about 5 months in overall survival. So on the basis of this, the updated results, whilst bevacizumab was initially approved for all comers, via the CDF and NICE, that was retracted, and now it's only available for those patients with high risk features. This is Bev as monotherapy. But now we're in a completely different era, and really we no longer have the option to just follow up patients. There's been a plethora of new drugs, mostly PARP inhibitors in this field, and therefore any patient with advanced disease will now go on to some form of maintenance treatment. So we still have the option of bevacizumab monotherapy for the high-risk group patients, but we've now got the option of olaparib, a PARP inhibitor, niraparib, a different PARP inhibitor, or the combination of olaparib and bevacizumab. So these are all approved, they're all licensed, and they're all available either by the Cancer Drugs Fund or equivalent in Scotland. And then more recently, I include rucaparib, which is a third PARP inhibitor. There's positive data supporting its use, but it doesn't yet have a license. That's relatively recent data. And how do we decide what we give our patients? Well, if you only remember sort of one thing from today, this is the kind of key figure. We're now looking at biomarkers to choose the optimal maintenance therapy for our patients. And the patients are essentially grouped into one of 3. You have those with the BRCA mutation, those that are BRCA wild type, so they don't have a BRCA mutation, but their cancers are still homologous recombination deficient, or the remaining patients which are homologous recombination proficient, or sometimes they're called HRD negative. And these are the different options that we have in terms of maintenance therapy. And I'll just go through some of the data surrounding this. But I think, first of all, it's important to understand what we mean by HRD. So data from the TCGA, this was the Cancer Genome Atlas, this is again almost a decade old, showed this demonstrates the most common recurrent recurring mutations in high-grade serous. And, you know, we've known for some time that HR is important because of the role of BRCA and the incidence of BRCA mutation, but also there's this other half, bottom half of the quadrant, all these other mutations or abnormalities in genes known to be involved in homologous recombination deficiency, homologous recombination. So about half of the cancers were predicted to have defective homologous recombination. And just as a reminder, BRCA mutations, the most common hereditary mutation in ovarian cancer, actually accounting for a significant proportion of ovarian cancer cases. So about 12 to 15% of patients with high-grade epithelial, particularly high-grade serous cancer, will have a germline or a hereditary mutation in either BRCA1 or BRCA2. So the presence of a hereditary mutation increases your lifetime risk of breast cancer and ovarian cancer. And because amongst our patients, the incidence is so high, we have been doing germline BRCA testing for all patients with high-grade ovarian cancer for several years now. Obviously, it has important implications for treatment, as you'll see, but it also has important implications for risk of second cancers, particularly breast cancers, and also for family members. So anyone who we identify a positive germline mutation, we would refer on to the genetic service. But there's also a smaller group of patients, about 5 to 7%, who will have a somatic BRCA mutation. That is a mutation that has arisen in the tumour during tumorigenesis. Now, that will have the same implications for treatment, but it doesn't have any implications in terms of risk of second cancers or family members. So overall, about 20%, so 1 in 5 of our patients with high-grade serous epithelial ovarian cancer will have a mutation in BRCA1 and BRCA2. However, the role of homologous recombination extends beyond that. So taking you back to your basic biology, and you'll remember that our DNA is constantly under attack from endogenous and exogenous sources, and damage to DNA can either be single strand, which is fairly easy to repair because you've got your template DNA, and there's a number of mechanisms: base excision, mismatch repair, nucleotide excision. But if a cell fails to repair the single strand break at the time of cell division, that will then become a double strand break, or you can get de novo double strand breaks. And this is much harder to repair, but over time we've evolved to have 2 types of double strand repair: homologous recombination, which is highly accurate, and non-homologous end joining, which is a bit more error prone. And when we're talking about homologous recombination deficiency, or HRD, this is the pathway that's defective. So about half of ovarian cancers have a defect in this pathway. Now, we've known for a long time this is important in ovary cancer because BRCA1 and BRCA2 are key proteins in mediating homologous recombination. So by definition, anyone with a BRCA mutation will have a homologous recombination deficient cancer, but there are obviously other proteins involved in that process. Now, why this is important when we think of therapeutics is because many of the single strand repair mechanisms are mediated by the PARP1 and PARP2 proteins. And as the name suggests, PARP inhibitors, they inhibit this pathway. So you treat a cancer cell with PARP, you get this accumulation of single strand breaks, which in a cancer cell with defective homologous recombination, such as a BRCA, they can't repair that. So you get this massive accumulation of DNA damage and ultimately cell death. And this is why PARP inhibitors work so well in patients with BRCA cancers, which you'll see, but also why other causes of HRD equally sensitized to PARP inhibitors. So how can we detect HRD? Because it's obviously important in about half of our patients. We can either look for the cause, we can look for the consequence or the phenotype of HRD, or we can do a functional assay to look for current HRD status. The problem is, with the exception of BRCA1 and BRCA2, mutations in any of the other HR genes are present at actually very low frequency, as you can see from the bar chart here. So the cumulative frequency of mutations in all the other homologous recombination repair genes is equivalent to that of BRCA1 and BRCA2. So it's not particularly cost effective to search for individual mutations. We know that there are germline mutations in a couple of other genes that may predispose to ovarian cancer, particularly RAD51, C and D, and BRIP1. And certainly in certain parts of the country, the panel testing that we do, the germline testing for BRCA, also includes these genes. So we do identify a couple of patients this way. a number of the patients with BRCA abnormalities due to BRCA methylation, about 13%, and then a smaller number with RAD51 methylation. And these epigenetic modifications are not picked up particularly well by current NGS strategies. So by doing just testing for the genes, we may miss this. And then finally, we don't really know the implications of both the epigenetic modifications and mutations in some of the HR genes in terms of predictive and prognostic effects. So really, with the exception of BRCA 1 and 2 and maybe a couple of others, we don't really know how important each of the mutations in these individual genes are. However, because any cancer with homologous recombination deficiency is more dependent on other types of DNA repair, so it's dependent on non-homologous end join and single strand repair, you get this classical pattern across the DNA of damage. You get this mutational signature, which you can see across the genome. So you get these typical patterns in the chromosomes. You get loss of heterozygosity, you get telomeric imbalance, so changes at the end of chromosomes, and you get these large-scale transitions where bits of chromosome jump around. And it's seen in a typical pattern in cancers that are homologous recombination deficient. And a number of assays, these are 2 commercial assays that have been developed to measure this HRD or genomic instability score. So the one we use in the UK is the Myriad test. It looks at the genomic instability score. So it's a composite score of these 3 markers of HRD, and it also provides a BRCA result. Or there's also the Foundation Medicine test, which just looks at LOH. Now, each of these assays, it's a continuous variable, the scoring system, and they have a somewhat arbitrary cutoff over which you're defined as HRD negative or HRD test, a score over which you're HRD negative, and below that you're considered HRD test negative, or sometimes called HR proficient. Now, the tests aren't perfect, but currently they are the best that we have. As I said, there are a number of other tests, with the exception of the Myriad and the Foundation one. None of the others have been prospectively validated, and there's been no prospective validation of the test to see which one compares better, and there never will be because they're both commercial assays. But a small study, academic study, looked at the comparison between the 2 tests, and disappointingly the positive agreement between 2 independent data sets was pretty poor, so 65 and 82%. So not a great positive predictive value, although the negative agreement was slightly better. One of the main criticisms of these tests is they fail to reliably identify the patients who won't benefit. So in all the studies that I'll show you, there were patients who were defined as HRD negative who did benefit. The second problem with these is that they represent a permanent historic footprint of what's gone on before in the cancer, and it doesn't change as the cancer evolves. So for example, if you have a BRCA mutation, you will, by definition, you'll have this HRD, the SCAR assay seen on a genomic instability score. If the tumour then acquires a second mutation in BRCA, which we see not infrequently, you can then restore the BRCA function. This is called a BRCA reversion mutation. So the cancer cell now has functional BRCA, and the homologous recombination has been restored, but the scar will still be there from before. So it doesn't really provide a real-time readout of what's happening in the tumour and represents what's gone on in the past. And we really need to work on a more sort of functional assay whereby you take a biopsy and you can get a real-time readout of what's going on in the tumour by looking at RAD51 levels, for example. Problem with these assays is that technically very difficult. You need fresh tumour. They need a lot of manipulation to get the results, and they're not really ready for mass scaling. So it's something that many groups are looking into, including ourselves, but it's not something that's yet ready for clinical prime time. So as it is, the Myriad and the Foundation ones are kind of the ones that are routinely used, and they're the best that we have. And they're certainly still better than having no option to test HRD. So increasingly, HRD status has been evaluated as a predictive biomarker when we think about response to PARP inhibitors. So you'll remember I showed you that if you've lost homologous recombination, you're more sensitive to PARP. So a number of the first-line trials listed here all explored whether HRD status would predict a better degree of benefit. And here this table lists all the first-line trials that have been published. I'm not going to go through them all, but essentially there's a number of key similarities and differences. For all of them, there was a fixed duration of PARP inhibitor, olaparib and rucaparib was given for 2 years, and niraparib was given for 3 years, and all of them had a primary endpoint of progression-free survival. But I'll show you the sort of 3 most important ones, the SOLO-1 trial being the first one. Now, This was a trial only for patients with a BRCA mutation. So they had to have either germline or somatic BRCA. And in fact, about 99% of the patients enrolled in the trial had a hereditary germline mutation. They had to have stage 3 and 4 cancer. They had to be good performance status and have at least an attempt at surgery. And following chemotherapy, they either had to have no evidence of disease, if they'd had primary surgery, or for those that had chemotherapy, they had to be in evidence of a response, so either a complete response or a partial response. And they're randomized 2-to-1 to receive olaparib or placebo. Now, patients received drug for 2 years, with the exception of anyone who had residual disease when they entered the study. If they were still benefiting, they could have treatment beyond 2 years. And that's how we now prescribe the drugs in clinic. And the primary endpoint was progression-free survival. So here, this was the results from the initial presentation from 2018 showing the progression-free survival. And what you can see is a huge separation of the curve. These are months along the bottoms, not weeks. And in the placebo group, the median PFS was just over a year. This is progression-free survival from starting the trial, so about 6 months after diagnosis, because all have had their chemotherapy. And you can see for the patients treated with olaparib, it hadn't been reached at this point. Hazard ratio of 0.3, and at 3 years, there was a 70% reduction in the risk of progression. So 60% of patients treated with olaparib versus 27% of patients treated with placebo. So a massive improvement. You know, remember I said with the bevacizumab trials, it was about 3 to 4 months improvement in PFS, and we were excited about this. You know, this is huge. And when we looked at the longer follow-up, you can see that in the olaparib group, the median progression-free survival was 56 months, so over 4.5 years, compared to 13.8 months with placebo. So, you know, you're improving progression-free survival by 3 years, which I'm not aware of any other trial where they showed such a great magnitude of benefit. And then on the basis of this, EMA and FDA approved olaparib for patients who'd responded to first-line chemotherapy and who had a BRCA mutation. And then just at ESMO last week, they presented the overall survival results, which the data is not yet mature because the patients in the olaparib group are doing so well. But you can see here at 7 years, there is 67% of the patients treated with olaparib are alive, compared to 46% on placebo. And that's despite the fact that more than half of the patients in the placebo arm went on to receive PARP at a later stage. So a 20% improvement of survival at 7 years. And in terms of PFS, just under half of the patients, so about nearly 50% of the patients, remain free from progression at 7 years, which is really quite remarkable. And, you know, we hope with long term that this will translate into a cure for some of these patients. Obviously, that trial only included BRCA patients, which was about 20%. So what about everybody else? Well, the PAOLA and the PRIMA trial looked at this. So the PAOLA trial, again, very similar inclusion criteria, apart from the need to have a BRCA mutation. And the difference being here that patients had to have had concurrent bevacizumab with their chemotherapy. Now, this trial was performed in mainland Europe, where Bev is the standard of care regardless of stage, so they don't have the same restrictions to use that we had in the UK, and therefore it wasn't felt to be ethical to have an olaparib only arm. So that's one of the main faults of the study, is that there's no olaparib only arm. So patients either receive concurrent olaparib for 2 years and 15 months of bevacizumab, or placebo for 2 years and 15 months of bevacizumab. And again, the primary endpoint was progression-free survival. And this is it for the whole population. So, you know, it doesn't look so impressive when we think about the SOLO-1 data, but actually still a over 6-month improvement in progression-free survival across the population as a whole. But when we split it up by biomarkers, this is when you really see the power of the biomarker analysis. So here, this is the HRD positive patients, so included the BRCA patients, but also the non-BRCA patients, and a median PFS of 37 versus 17 months, a 20-month improvement in progression-free survival, highly significant hazard ratio. Now, the cynics amongst you could say, oh, well, that's just because the BRCA patients are included. But actually, if you take out the BRCA patients, you just have the HRD non-BRCA patient, still a substantial improvement of 12 months in progression-free survival. And then when we look at the HRD negative patients, or those that the status was unknown, absolutely no benefit in adding olaparib to bevacizumab. So almost identical curves here. So on the basis of this, the Europe and the US approved the combination of olaparib and bevacizumab for patients who responded to first-line treatment and who had HRD cancer either by positive genomic instability score and or a BRCA mutation. And again, at ESMO, they presented the overall survival analysis. And for the HRD positive subgroup, you can see a significant improvement in overall survival from 57 to 75 months. In the olaparib group, it's thought to be unstable because they've not really had enough events. But again, looking at 5-year survival, and that's sort of 18% improvement in 5-year survival. So really massive improvements in outcome. And it's rare to see improvements in PFS translating to improvements in overall survival, particularly in ovarian cancer where patients may live for many years and have multiple lines of treatment. So this really shows the importance of early instigation of these therapies, which translating into long-term outcome, with many of these patients being free from progression at 5 years. And then the third trial I'm just going to talk about is the PRIMA study. This used a different PARP inhibitor, niraparib. The main difference with this study is it included more high-risk patients. So if you were a stage 3 patient and you had primary surgery, you had to have disease left behind. So these were the kind of old BEV high-risk patients, so residual disease, no surgery, stage 4, etc. And they were randomized to niraparib or placebo. Initially with niraparib, everybody got 300, and then halfway through the trial, they introduced this individualized starting dose based on body weight and platelet count, because if any of you treated patients with 300 milligrams of niraparib, you see a lot of thrombocytopenia. So with the dose adjustment, that improved that specific toxicity. And again, primary endpoint PFS. So there's a similar pattern with each of these trials. Here we see for the overall patient population about a 5-month improvement in PFS. So not dissimilar to the Paolo study, but the overall numerical values are less. But remember, these are a higher risk patient population. And then again, when you take out the HRD patients, you see this substantially greater gain, so about 11-month improvement in progression-free survival. So, Paolo data very similar, 12-month improvement in PFS by giving PARP inhibitor in HRD patients. When they broke it down by subgroups, you see the same pattern, biggest benefit in BRCA, then in the BRCA wild type, but still HRD. And interestingly, in this study, although it's hard to see with the curves, there was an improvement in PFS in the homologous recombination proficient patients of about 3 months, so from 5.8 to 8.3, I think, which was statistically significant. So on the basis of that, the EMA and FDA actually approved niraparib for all comers who'd responded to first-line chemotherapy. And the updated survival data for this trial is due to be presented next month at ESGO. So it'll be interesting to see if you see the same benefit in survival across the patient subgroups. Just for your awareness, the Athena trial looked at treating patients with rucaparib, the PARP inhibitor rucaparib, and there was also an arm with and without the immune checkpoint inhibitor nivolumab. The initial data from the rucaparib versus placebo was positive, very much to that seen in PRIMA. So benefit seen across all subgroups with incremental reduction as you go from BRCA to HRD to HR proficient. And then the PRIME study was very similar to the PRIMA study. This was in better risk patient population, and it was done in a Chinese population with a different HRD assay. And again, they saw similar pattern response across all subgroups, but the greatest in the BRCA and the HRD. So this forest plot compares all the various trials, and I include it not because we shouldn't be doing cross-trial comparison, but just to show you that you see this recurrent theme. So here we've plotted the hazard ratio of response to PARP inhibitor, and you can see that the greatest benefit is seen in the patients with a BRCA mutation. So consistently, the hazard ratio is about 0.3 in all the trials. I didn't present the results from the Velia trial because that used a drug called olaparib, which has not got approval anywhere in the world. Then you see this hazard ratio of about 0.4 with the patients that are HRD but BRCA wild type, and then it's slightly less consistent with the HR proficient patients. So you can see that in the PRIMA trial it was statistically significant. The other two, the hazard ratio crosses 1. I think that this really highlights that whilst the HRD assays are useful and they certainly help us select the patients who will derive the greatest magnitude of benefit, they don't reliably identify those that won't benefit. So there are a group of patients in the HRD negative or HR proficient group who do still benefit from PARP. It's worth noting that HRD status is also a prognostic factor. So here, I'm sorry, this is a bit blurred, but this is the data from the placebo arm of the PRIMA trial. That was the niraparib trial. And you can see that the yellow line, the HR proficient patients, really have a pretty poor prognosis. So their median PFS without any maintenance therapy is 5.4 months after completion of chemotherapy. Compared to the BRCA patients in this group, it was 11 months, and the HRD 8.2. So not only is it predictive, but it's also prognostic. And that's something worth considering when we're talking to our patients. So I show you this figure again, because now we've gone through the data behind it. So the patients with the biggest number of options is the BRCA mutant patients, because they have access to all of these drugs. I would argue that both for the BRCA and the HRD, BRCA wild type patient, bevacizumab monotherapy is not really an option. The benefit for PARP inhibitors in these patients is so great that there has to be an extremely good reason not to give a PARP inhibitor for those patients. But these are the options as they stand, and this is what we have available to us in the UK. So how do we decide? Well, it's unusual in oncology, particularly in ovary cancer, to have a choice of what we can do and to have all these great options, but we have to consider disease characteristics. So what are the tumor-related symptoms? Do they have residual disease? What are their biomarker status? What are the results of the BRCA and HRD? There is slight nuances, not so much in the UK, but across Europe and the world, about what drugs are available in what different setting. Think about the safety and the efficacy. So I haven't gone through the toxicity data in the interest of time, but there are quite marked differences between the different PARP inhibitors in terms of toxicity and for example, dosing. Niraparib is once daily dosing, olaparib and rucaparib are twice daily. They have different side effect profiles. Obviously, bevacizumab is IV, so that has implications in terms of service provision, chemotherapy chairs, but also huge impact on patients having to come up every 3 weeks for IV therapy. And then we have to also think about drug-drug interactions. Olaparib is metabolized by the CYP family of enzymes, so there are a number of medications that should be avoided when using olaparib, whereas niraparib does have slightly less drug-drug interactions. And then obviously the most important thing is, what does a patient want? If we talk about their options, what are they willing to accept? And what are their comorbidity? And have a think about their quality of life. So I'm going to give you a very quick case study to see if you've been paying attention or you know what the answer is, just to see what options we have. So this is a patient of mine who was diagnosed about 18 months ago, 51, extremely fit and well, no significant past medical history, no relevant family history, and no real comorbidities. Presented with the typical symptoms: abdominal distension, weight loss, found to have an elevated CA125, CT scan demonstrated bilateral adnexal masses, a mental disease, disease on the diaphragm, subserosal liver deposits. So typical distribution of disease. Our MDT feeling was that she would be a candidate for primary cytoreductive surgery. So she underwent surgery. She had a big operation, posterior exenteration, primary bowel anastomosis, omentectomy, hysterectomy, oophorectomy, resection of a small bowel. So 2 bowel resections with no evidence of residual disease at the end of surgery. And one of the biggest predictors of outcomes is the amount of disease at the end of surgery. As you would predict, those with no disease do significantly better than those with small volume and versus large volume disease. So the final stage was a stage 3C. She had bulky deposits outside the pelvis, high-grade serous ovarian cancer with the typical immunohistochemical pattern, so ER, PAX8, WT1 positive, and P53 mutant, which is almost ubiquitous in high-grade serous. She came to see us, consented her for BRCA testing, requested HRD testing, and commenced carboplatin and paclitaxel. And one of the slight nuances of the now that we have the availability of the bevacizumab and olaparib combination for HRD is that within the confines, certainly in England, of the Cancer Drugs Fund, we can start bevacizumab with the chemotherapy pending the HRD result, because we don't want the patients to miss out on the opportunity of having the combination. So when you request it by the Cancer Drugs Fund, you request it for concurrently with chemotherapy, and then you have to do a separate request for as maintenance treatment if indeed they're HRD positive and you want to carry on. So historically, we couldn't have given her bevacizumab because she had no high risk features, but we are able to do it in the one of the kind of nuances of the way we prescribe now. We got the results of our HRD test. So the BRCA germline BRCA was negative. The somatic BRCA within the HRD test was negative or wild type, but she had a very high genomic instability score of 67. So she completed her chemotherapy and there was no evidence of disease. So the question is, what are her maintenance options? So to recap, she had primary surgery with no residual. She was a stage 3C. She was BRCA wild type or no BRCA mutation, but HRD positive. So I've listed them here, and Dan tells me that there's a poll that you can do. So these are the different options. Which ones are available to her? Okay, so I appreciate it was quite a complicated slide with lots of information, and we really got answers about across all the different options. So let me talk it through with you. Thank you. So the first thing to say is that the option of bevacizumab as a monotherapy, it doesn't exist because she doesn't have any high risk features. So we cannot give bevacizumab as a monotherapy. Now, if she did, in theory, we could, but we would usually exclude Bev as a monotherapy for patients that were HRD just because of the great benefit they get from PARP inhibitor. And then the second drug that we can exclude is the olaparib, because that's only available for those with a BRCA mutation. So the options that she has, being HRD positive, is the combination of the combination of bevacizumab with olaparib, which is approved for HRD cancers, or niraparib as monotherapy. And actually, this is a discussion that we often have with patients. We don't really know the additive benefit of Bev in addition to PARP. And obviously, it comes with the inconvenience of IV treatment. So this is often we have a sort of negotiation, a detailed discussion with the patients which one they want to go for, because you can't hand on heart say that one's better than the other. But they are the options that she has available to us. So well done for anyone who went for number 3. So just to confirm, options 1 and 2 and 5 are out because she's not eligible for olaparib monotherapy, and the others are out because she's not eligible for bevacizumab monotherapy. Anyway, so she's been on that treatment now for about 15 months and has no evidence of recurrence. So we're just about to stop the Bev because we give that for 15 months, and then the olaparib continues for 2 years. Okay, so that's her. So very briefly, with the last few minutes, I'm just going to touch on the management of recurrent disease. So, despite these great advances, even in the patients with BRCA mutation, half of them do recur. And how do we manage that? And it really depends on the interval from their last chemotherapy. So whilst the definitions have changed slightly, so historically, how we defined patients was from their last dose of platinum chemotherapy, and they were considered platinum refractory if it was in 4 weeks of their last chemo, platinum resistant if it was less than 6 months, and platinum sensitive if it was more than 6 months. Now the guidelines have slightly merged the bit between resistant and sensitive, and the ESGO BGCS guidelines suggest that as long as it's more than 6 weeks since platinum and they had previous evidence of response to platinum, then it may be reasonable to re-challenge with platinum-based chemotherapy. So I'll show you the different options in terms of systemic therapy. But one thing we should always consider is whether another operation is of value. And this, the data now suggests that it may be. So this is a trial looking at secondary cytoreductive surgery. So this is for patients who had their first recurrence of platinum-sensitive ovarian cancer, and they were randomized to receive surgery following chemotherapy or no surgery following no surgery and then standard chemotherapy. And remarkably, they recruited 400 patients over 5 years to a surgical trial. It's actually quite difficult to do when you tell the patient, so you might not get an operation, because often patients feel that the surgery is their best option. To be suitable for this trial, you had to have a positive AGO score, and that means performance status 0, so not even 1, very good performance status. Minimal ascites estimated to be less than 500 mils or no ascites. And importantly, at the time of primary surgery, you had to have had complete macroscopic removal. Platinum sensitive disease, so there had to be 6 months, but the majority of patients on the trial had over a year since their last chemotherapy. And obviously they had to have evidence of progression. And here what we see, this is the overall survival. So actually quite a significant improvement in overall survival by having a second operation, 53.4 versus 46 months. And in the patients that had complete disease resection, the median overall survival was 61 months, so more than 5 years from first relapse, which is quite remarkable. The important thing to notice is that on this trial, patients that underwent surgery but had disease left behind did much worse than those that had no surgery. So really, we should only be considering a second operation in patients who have got disease that we have a realistic chance of clearing. And all these operations should be done in big cancer centres, because really the impact of in suboptimal surgery in this setting, and indeed in first line setting, is really significant in terms of survival outcome. So anyone who recurs, if they've got platinum sensitive disease, it's always worth considering whether another option is feasible and whether it's the right thing to do. And increasingly, we've been doing more of these operations over the last few years since this data was presented a couple of years ago. And then in terms of systemic therapy for recurrent disease, platinum sensitive, so like I said, anyone over 6 months and anyone who's responded to platinum and is at least, I think most of us would only do it if they were sort of 4 months plus, but by the new guidelines, we can re-challenge with platinum, even if it's only 6 weeks from your last platinum, provided you responded before. But I haven't seen many responses in that category. But for those with platinum sensitive disease, definitely those with 6 months and above, we would normally re-challenge with a carboplatin doublet chemotherapy. So Calyx, gemcitabine, paclitaxel again. And all of those patients, if they were predated the first line PARP, they would all be eligible for PARP inhibitor in the recurrent setting after chemotherapy, because there's a benefit has been shown in this setting, or obviously a clinical trial. For those with platinum resistant disease, I've listed the options here. None of them are particularly good. There is a small benefit of adding bevacizumab with certain chemotherapy regimes in this setting. It's available in Scotland in this setting, but not in England. But overall, the median progression-free survival for these patients is pretty abysmal. It's about 3 to 4 months, and the overall survival is about a year. So this is really an area with unmet need where we need to do further research. But as I said, the kind of management of recurrent disease could take a whole hour in itself, but that's just to highlight kind of where we're at. So in conclusion, I hope you agree that we're in this really increasingly, this exciting time of increasingly personalised medicine for patients with newly diagnosed ovarian cancer. It wasn't that long ago that all histological subtypes were treated the same. Not only do we treat histological subtypes differently, but we have different first-line maintenance options depending on your BRCA and your HRD status. Not only does it improve progression-free survival, but it improves overall survival with a 20% improvement, 5 years in the Paulo, the olaparib Bev combination, and a 20% plus improvement in overall survival at 7 years in the BRCA patients treated with olaparib. We need to be doing HRD and BRCA testing on all our patients. We need to be doing it early on in the treatment paradigm so that we can make decisions adding bevacizumab if we need to. But despite all this positive stuff, there are significant areas of unmet need. HRD negative patients do not do well prognostically and predictively. These new drugs are really only relevant to the high-grade serous histologies. What about clear cell mucinous endometrioid? And what do you do when they develop PARP resistance? Because whilst I said the outcomes are really great, there's still the majority of patients unfortunately will relapse at some point, and it's difficult to know how to manage patients in the context of progression on PARP inhibitors. So thanks very much for your time, and I'm happy to take any questions.
Thanks, Rowan, for another really great and informative talk. To start off, I actually just had a few practical questions, Rowan, about doing the GIS scores. So how much tissue do you need? Is it usually okay just on the omental biopsy? And
thanks, Helen. So currently we have access to the GIS score, the Myriad test. It's funded by AstraZeneca, who make olaparib, and that may change in time. But until recently, we had quite a lot of fails on the diagnostic biopsies because of insufficient DNA. Two things have happened. The pathologists have got better at identifying, a more representative slide, but importantly, they now require far less DNA. So we can, we nearly always get results on core mental biopsies on the patients having neoadjuvant chemotherapy. If possible, though, certainly in our centres, we take extra cores just so we've got a bit more tissue. So if you can take 3 or 4 cores rather than 2, just ensures that there'll be enough tissue. The problem is sometimes if patients have neoadjuvant chemotherapy and have a really good response, particularly in the HRD, then you don't then have enough viable tissue at the time of interval surgery to send in.
And is it sent automatically by the pathology department, or do you request it when?
It's a bit dependent, centre dependent, because on the form they have to say that the patient has consented to BRCA. So I work at UCLH and Barts. At Barts, the pathologists automatically send it. At UCLH, they check on the record that there's documentation of consent. And some of them we request through the MDT, so it's slightly different in different centres.
Okay. So you don't have to consent for the HRD testing, it's just the BRCA testing?
No, you just have the consent for BRCA, because as part of the HRD, you get a BRCA result. Now, some people would argue, well, it's a somatic test, you then have to follow up with germline testing, but as we usually do them concurrently, we normally send off germline. BRCA, when we do the tumour testing, I always consent them for BRCA.
And another question I had, in terms of the combination treatment with olaparib and Bev, how much toxicity is there? And are there many patients you see that are eligible for both, but you don't give the combination to because of that? Or are there any other reasons for not giving it?
The main reason not to give it is a contraindication to bevacizumab. So I've had a couple of patients recently, for example, who've had a big pulmonary embolism, which is not an absolute contraindication to Bev, but it is a slight contraindication. And then a couple of people who've had, say, ileostomies that are waiting reversal, and we're going to operate immediately after chemo, we can't get the Bev started, or they've had lots of problems with their bowels. So there are a few, but it's pretty well tolerated. I think there's probably a bit more toxicity because we give it in the combination at the higher dose at 15 mg per kilo, whereas as monotherapy it's 7.5. So I think I do see a bit more arthralgia and hypertension, but it's not particularly, I think it's pretty well tolerated. I think the main issue is having to come up for IV treatment. So that's often off-putting for patients.
So would you have an age cut-off where you'd say not to give the combination, or not really?
No, I think you have to take all the individual characteristics. And personally, I think if it's a patient who has lots of high risk features that you would have given bevacizumab to before, so say they had residual disease or they were stage 4, they had lots of ascites, then I quite like to give them a combination if I can, because I just know that they're higher risk. If they were, say, a primary surgery, stage 3, no additional risk factors, then I'd be more comfortable just giving them the niraparib monotherapy. But really, I don't think there's a consistently right answer for any individual group of patients. I think it's all based on, the factors that I showed you and what the patient wants. Because sometimes they'll have very strong opinions. They want everything, or they don't want IVs or whatever.
Okay, thank you. One last question from me. Sorry. The functional real-time assays you were talking about are for a kind of an alternative to the Myriad MyChoice testing. What sorts of assays are they?
So it's looking at RAD51 foci, or the formation or lack of formation, but the issue is that you normally need a part of tumour and then you expose it to something that causes DNA damage, so irradiation or cytotoxic chemotherapy, and then you get a readout of RAD51. So they're technically quite tricky because you need to do something to the tumour, and they need to be fresh tumour. So they're just, but there is a group in Barcelona that are developing them on FFPE, so they might then become more mainstream.
Okay. Thank you very much, Rowan. That was a really excellent talk.